Welcome to the Psych to Practice podcast. Before we get to today's conversation, we want to highlight something special about this episode. It's part of our continuing education series, which means you have the opportunity to earn CE credits. So here's how it works. After you finish the episode, head over to psychtopractice.com. You'll see the episode listed with a short exam designed to reinforce the material covered. When you purchase and complete that exam, you'll have access to the CE certificate to apply towards your professional continuing education requirements. We know how important continuing education is for mental health professionals. It's not just about maintaining licensure, it's about staying current, sharpening your skills, and bringing fresh insights back to the clients you serve. That's why we've designed this process to be as smooth and flexible as possible. You can listen on your commute, during a break, or whenever it fits your schedule, and then take the exam at your convenience. Now, for those of you who want more than just an individual exam, we've created the Brightminds subscription. With Brightminds, you're not limited to just a single episode. You gain access to our entire library of CEU-eligible podcast episodes. Plus, gain access to exclusive home study webinars on emerging topics in psychology, and you'll have the chance to register for live events where you can engage with the presenter in real time, ask questions, and connect with other professionals. Think of Brightminds as an all-in-one continuing education hub. Whether you're catching up on demand or joining a live session, you'll find content designed to meet you where you are in your professional journey. It's an efficient way to stay engaged with evidence-based practices, earn CEUs, and be part of a community that's passionate about advancing the field. So you have options. If this episode stands out and you'd like a CE credit for it, you can purchase the exam individually. Or if you're ready to broaden your learning and take advantage of our full range of resources, Brightminds may be the perfect fit. Both are available right now at psychtopractice.com. With that, let's get to today's CEU eligible episode of the Psych to Practice podcast.
Welcome to the Psych to Practice podcast, your one stop for practical and useful clinical information, masterful insights from experts in the field, and a guide to daily living. I'm Ray Christner, and with me,
Paul Wagner.
So thank you for joining us today, and we are really excited about having another Masters in Practice episode and had a chance to talk to Dr. Aaron Brinen.
And, really kind of diving into his book, Living Well with Psychosis. And, we've talked with a lot of authors, and I don't know that we've ever really talked about psychosis, and not intentionally, but it's a topic that at times can feel really challenging or hard to approach. And I think Aaron just turns that on its head. The conversation was so easy. And the way he's talking about some of these areas that, personally, it was really limited experience in treating psychosis. I did not feel very strong. And yet the way he's talking about it and he presents it in this book, it just makes it so approachable and pulls on the skills that have already been developed while also kind of laying the groundwork for developing the skills to supplement with it what isn't there already.
Yeah, I mean, it was interesting as I read the book. I mean, I read a lot of different things and a lot of CBT things, but I love when somebody can take and make me think different about a topic that I think I know a lot about. I thought the book really gave me some great thoughts about CBT. And, psychosis is not an area that I've done a lot of work in. And it became so approachable as I read the book and kind of, he talks in the book about myth busting. He busted a few of my myths, which I thought was really good. And this was a great conversation. And, so his book, Living Well with Psychosis, is really a self-help book. So it's for individuals that have psychosis, but it's also appropriate for clinicians. And, you're going to hear in the episode, we talk about family members as well. So, I mean, it really, I could see using it in a lot of ways. And even, again, we kind of talk about this. There are some things in there that even if you're not working with psychosis, you could really use some of these strategies and the way he approaches it, I think, well with other populations.
Absolutely.
So for those who are not familiar with Dr. Brinen, he co-developed recovery-oriented cognitive therapy, or CTR, and adapted it for various settings. He authored Living Well with Psychosis and co-authored the original CTR manual. As a clinical psychologist, he provides evidence-based treatments for severe mental health conditions. He is also an assistant professor of psychiatry and behavioral sciences at Vanderbilt University Medical Center, training therapists globally in CTR. A blogger for Psychology Today, he creates teaching content on social media platforms. And you'll hear at the end of the episode, YouTube's a big one, I think, for him.
Yeah, no, and I hope you enjoy this episode. I think that there is so much valuable information. And, please, anyone who feels like it's not an area of an expertise, or if it's an area you feel very strong in, I think this is a great read. But with that, we hope you enjoy this Masters in Practice episode, Living Well with Psychosis. So, Aaron, welcome to the Psych to Practice podcast. Thanks so much for joining us today.
Thanks for having me.
Yeah, we're really excited. So, a former PCOM alumni. So together, it's so funny. We get people who have similar backgrounds, and I'm like, I don't think we ever met face to face, and we were kind of there really at close times. So
exactly. And had very similar experiences. Like, I've known your name for a very, very long time. So when they sent me the link, I went, oh my gosh, I'll finally get to meet Ray. Oh, yeah.
Right. Yeah. That's how it always works, right? It's like we hear about each other. So really so glad to have you join us and, really to talk about your book today. But before we kind of get into the book and some of the content, we like to give our audience a little bit of background. So we want to hear a little bit about your origin story. How did you get into psychology? And tell us a little bit about that.
Sure. I always love this story. So whenever I've met with research assistants, I always say, I don't know that I've got the weirdest story, but I will bet that I'm in the top 5. I actually went to my undergrad to be a theater major, and I was a theater major. So my bachelor's of arts is in theater arts.
Okay.
When I was at PCOM and I was teaching Psych 101 at Montgomery County Community College, I had kids. My wife had kids while we were at I was at PCOM, and so they like to eat and everything like that. Right. So whereas like every other class that you would teach, like psychopathology or whatever, you could say like, listen, I passed psychopathology. I don't need to pass this class. I could never say that about Psych 101 because I never took Psych 101 until I taught the class. I had a theater major. Wow. Isn't that a wild one? So I went and I was living in LA and I had accomplished all of these things that I had wanted to accomplish, right? A series of things. And I'd had success in LA and I had just gotten married. And my wife was working in early childhood education. And she started describing about how she wanted to help kids who had lost a parent. And I very casually said, oh, you want to be a psychologist? And she goes, no, I could never be a psychologist. I said, you could absolutely be a psychologist. And I kind of explained to her, I was like, yeah, this is what it is. And the more I talked to her about being a psychologist, the more I remembered that there were sort of 2 roads when I went to Penn State that I could have gone down. And I was very happy with the road that I went down. I recently said to my son, not all those who wander are lost. And so I took that path. And yet then there's this other path. And at that time in my life, the idea of like going away for like 3 years to shoot a Lord of the Rings movie in New Zealand, a year earlier, that seemed like the greatest thing in the world. But as this newly married person being sent away for 3 years, it seemed more like a punishment at that point. And there was this thing that I remember that I was very interested in. Well, I happen to have a bachelor's. And so I called up a local school and I realized I could get my master's. I had all of the requirements with the bachelor's of arts and theater arts. I had all of the requirements to get a master's in psychology with an emphasis in marriage and family therapy. Sure enough, I think about 2 weeks to a month after having that conversation with my wife, I'm sitting in Encino, California in classes learning about psychology. And so it was very funny because a lot of the people in the master's program, they had gotten bachelor's in psychology. So we're learning about classical conditioning, and they're rolling their eyes because they've had 3, 5, 7 classes on classical conditioning. Not me. It was fascinating. I'm like, can you believe this? The dog, his mouth starts going because of the bell. Is that so cool? But that's why I get so anxious, right? And so, everything was like amazing to me, right? It was like everything was new. And I remember my practicum that I had to do was I did a drug and alcohol program. It was called a drug-free program, which actually we did harm reduction. Don't ask. I'm not sure. But I remember this moment when I sat in the seat for the first time. And I started serving the first individual, and they came in. And I describe it a lot. Like it felt, I came home. Like that seat it felt like where I belonged, like my whole life. I remember coming home and speaking to my wife about it, going like, it felt so right. And it started this sort of insatiable hunger of going. So interestingly, since we know similar people, I graduated. And at that point, family back east, people were starting to have kids, we hadn't, and so, but we wanted to be closer to family because we were from back east and we're living in California. Mm-hmm. So I start thinking about, what if we move back east? And so we tell my family at my graduation, we're going to move home after I get licensed as an MFT. And that's going to be in 2 years, right? So this is May, I'm graduating. They're like, okay. So I call up this psychologist named Dr. Felgois. And so I talk to Stephanie Felgois on the phone, and I talk about what it is to enroll and the program and all of that stuff. So remember I said we told my family in 2 years we're going to move home at my graduation? Yeah. August, we sold our house, packed our 2 dogs in the car and stuff, drove cross country, and I had a job in Philadelphia treating individuals. Applied, and I was enrolled in PCOM. Right. Also, by the way, anybody who's following along at home, I was a catch. I literally got married in 2001, and I immediately was enrolled in school for about 10 years. I was in education between a master's, a doctorate, postdoctoral hours. Right. So I owe my wife a lot. And so this is this journey that I ended up on, really with this desire to serve individuals with PTSD. And my goal was to learn how to help those, particularly it was at the time GWAT had just begun, the Global War on Terror. And I saw people who were part of the original gunner trucks that had gone into Baghdad. I met somebody who was a part of that original group. And I thought, oh my goodness, all of these young people are going to be coming back, and they're all going to have PTSD. Not all of them, but many of them are going to have PTSD. Yeah. And we need people who can help them get back to their lives. And so I wrote every single paper at PCOM on the treatment of PTSD. And Bruce Zahn said, well, if you really want to learn how to treat PTSD, you should go to the Center for Treatment and Study of Anxiety. And I said, they would take practicum. He goes, you should try. And that's how, on a dark and stormy night, I went to the Philadelphia Behavior Therapy Association, had a talk, and Elizabeth Hembry was speaking there. And I was like shaking in my boots. And I went there and I saw her talk and just absolutely quivering. I walked up and I said, and I asked her, I said, have you ever thought about the fact that motivational interviewing is about the resolution of ambivalence toward a behavior? She goes, yeah. But I said, but avoidance is a behavior. And so possibly to accentuate the treatment of prolonged exposure for PTSD, what if we applied motivational interviewing to avoidance? She goes, I've always thought about that. I said, do you ever take practicum students? She goes, I'm the director of clinical training. And to this day, she was my mentor. She was on my dissertation. Wow. And she's a really good friend. And so I kind of go through it. I go to Coatesville and do my internship where I get some really cool, amazing opportunity to serve veterans. And then it's time for postdoc. And I had 2 options. So I went back and I interviewed again to go back and do a postdoc at the Center for Treatment and Study of Anxiety, where I actually did do a practicum there, and I did my dissertation with their data. And then I was told you should apply to the psychopathology research unit. And I'm like, what the heck's that? They go, that's Aaron Beck's unit. And I went, I can never work for Aaron Beck. They're like, you should do it. And I went and I interviewed, and they were doing an expansion of what's called the Beck Initiative, which was teaching community clinicians to do CBT. And they were doing expansion to teach children and adolescent clinicians to do CBT, to do cognitive therapy. And so I joined the Beck initiative in the child expansion, because when you got to pay the bills, do you know who pays
you got to pay
really
the bills?
Right? Drug and alcohol treatment, they don't pay. And that's one of the problems with our society. They won't pay for treatment of drug and alcohol treatment. Right. Child and adolescent, they'll pay you to go work in residential. So I've had a lot of experience doing doing child and adolescent treatment. And so, so I went and I did that, and I got to start working with, very far away from Dr. Beck, which was kind of like shocking. I remember the first time I met him, he goes, "So we have another Aaron." And I'm like, I was absolutely shocked. But then he was just doing his work on what they were calling back then cognitive therapy for low functioning individuals with schizophrenia. Not a very snappy name. Right. Also not a recovery oriented. And there was a postdoc who just really was having a tough time of it. And they needed people to fill in on some of her stuff. And he goes, "Aaron, have you ever run groups?" I loved groups. I said, "Yeah." And he goes, "Tell me about the group." And I told him about the group. And he goes, "Okay, you're going to help out with this." I go, "Okay, cool." So I meet with this amazing psychologist named Nadine Chang. And Nadine brings me in, and she's 9 months pregnant. I call her my psychosis mom, because Nadine sits there and she goes, "Listen." Also, the whole time she's doing it, she keeps exhaling really badly. And I'm really nervous. So every time she exhales, I think she's angry at me. Now, granted, I have a 5-year-old and a 3-year-old right now. I absolutely know what's happening is that there's a 9-month-old, there's like a 9-month gestational baby sitting on her diaphragm, so she can't breathe. But she goes, "There's these things called safety behaviors." I go, "Oh, safety behaviors, like social anxiety disorder. It's a behavior you engage in the short run that makes you feel better, but in the long run, it maintains the problems." No. Safety behaviors in schizophrenia. It's a behavior that you engage in the short run that makes you feel better, but in the long run, it maintains the problems. I was like, wait a second, let's agree to disagree. And then she starts explaining it. And I realized that psychosis is just this anxiety disorder that's gone hog wild. So every one of the interventions that I know about, that I learned about at the Center for Treatment of Anxiety, in my OCD work, in my PTSD work, in my panic disorder work, in all of the anxiety disorders work, I start like downloading all of these sort of ways, and I start fiddling with them and adapting them, and I start applying them. And I slowly get brought into it. And then I get taken to Pennsylvania Hospital, where Dimitri Perivoliotis, who's a very dear friend and co-author, who I call my psychosis daddy, he took me out and he showed me how to do it on the floor. Mm-hmm. And that's how I now come to here, which is sort of years later, I've developed, I helped to formalize recovery-oriented cognitive therapy and apply it all over the world, from taking it from an outpatient treatment to we've done it inpatient, state hospitals, ACT teams, first episode psychosis teams, in a boat with a goat, in a box with a fox, kind of like everywhere we can. So that's sort of that's most of the origin story. But
yeah. So it's interesting. So you take all this long path to come to do this work, and, it's interesting to hear how it all connects. But, so your book talks a lot about recovery-oriented cognitive therapy. So I don't know that everyone knows what that is. So we all know CBT, but tell us a little bit, kind of, what is recovery-oriented cognitive therapy? What's that mean?
So recovery-oriented cognitive therapy is an extension of CBT as it was applied to psychosis. Right. So probably about like 20, maybe 30 years ago, particularly in the UK, they applied Beck's model of anxiety disorders to psychosis. And so particularly they were focusing in on the positive symptoms, which are the hallucinations and delusions. And so they really focused on it, but it was also traditionally focusing in a very traditional cognitive behavioral therapy way of like, we've got a problem. Let's make a problem list. Let's tackle the problem one at a time, right? We were sort of problem hunters, right? And I don't know that many people do CBT like that. Not everybody does CBT that way, but that was very much the way that they would handle it. Really effective, has a good effect size for it. They've even gotten better now as they've gotten more specific towards specific symptoms. When Dr. Beck came back to it, Tim originally, I don't know that most people realize that while obviously Tim is very well known for his work with depression, anxiety disorders, suicide, all the stuff, right, all the way through. Tim's first case study was written in 1952. And it was of the successful treatment of an individual with schizophrenia with a delusion of borrowed guilt. Tim was a psychoanalyst at the time. Although I got to tell you, you want a good read, go back and read his 1952 paper, because there's two things. One, it's amazing. His writing is amazing. Two, you'll be like, it's psychodynamic, but really, is it psychodynamic? Like, it sounds as Tim could be, right? I'm saying, if you've ever heard him conceptualize or do therapy, it sounds like him. So when he comes all the way back years later, he goes to, just like he always did, he goes to the community, says, well, what do you need? And they said, listen, well, we've got coping skills. We've got medicine for the hallucinations and delusions. But what do you do for these individuals who have these problems with motivation, problems with connection, right? What we call the negative symptoms. Those are words like avolition, apathy, asociality, flat affect. He always says all the A's, right? Negative symptoms refers to where there should be something. It's been taken away. There's nothing, right? How do you handle those people? How do you help those people? We don't have anything. And it is true. There is no medicine from the FDA that helps with that. There are no digital therapeutics that help with that as of now. So we really don't have ways to help individuals with the negative symptoms of schizophrenia. And so he starts like he always did. He interviews those people and things like that. So recovery-oriented cognitive therapy privileges the negative symptoms, and we have a conceptualization of the negative symptoms, and we target it. And so it's based off of the idea that if we can get somebody more motivated, we find that they start doing more in their life. And think about it, anytime you've started doing more in your life, you have less time for the junk in your brain. And that for our individuals turns into hallucinations and delusions. And we actually got really good research to support that too. If you have less of the hallucinations and delusions, you're a little bit more motivated. If you're a little bit more motivated, you do more in your life. Right. So we focus more on the motivation and ultimately the recovery. And that's through what we want to be doing in our lives, the things we want to be doing, the things we want to get, what we refer to as aspirations. And we kind of decided we needed a new word because many of the individuals we've served, they've kind of been goaled to death. Every time they go to the hospital, people say, what's your goal? They get like tick, 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 and then nobody ever talks to them about it again. Right. It kind of becomes insulting. But we're also really looking for those big picture things. Right. I want to take my son and drive around Penn State and show him where I went to school, and I want to see him apply. Right. That's what we wanted. That's what we're talking about. We're not talking about like, I mean, how many people on this who are listening to this podcast when they were 7 years old thought, gosh, when I grow up, I really hope I can, take my medicine every day. But so often that's what's written down. Well, how is that going to motivate us to move forward? But as we take action toward these personal, meaningful, valued goals, right, we have less time for the things in our mind. And actually at the end of it, it's really straight down the center. Good old fashioned activity scheduling is the core intervention. It is a much more prolonged, protracted activity scheduling like you've never done it before. I mean, some people have, but like it's really squeezing all of the juice out of that lemon of activity scheduling and helping people sort of learn those lessons from activity scheduling. As other obstacles get in the way, we sort of target those as they get in the way of taking action toward the person's aspirations. And so that's why we think of it as recovery oriented, is we're really focusing toward that. And as obstacles get in the way, we target them to get out of the way.
And that leaves me curious, like in the development process of this, it really sounds like it's this approach that is so needed, but really wasn't there previously. How difficult was it trying to present this to clinicians and trying to get them to explore and adopt this after the research? And like, what was that initial response back?
Yeah, I think there are times where it can be hard. The people who know me and love me know that my patience is not always not the asset that they would put on LinkedIn, right? To say that. And it's not because I'm unkind. It's my wife always says to me, when it's an issue of social justice, it's the time when I'm at my worst, right? But one of the things that I actually always try to do is I try to conceptualize the individuals who are in front of me. Nobody goes into serving individuals with psychosis because there's like a bucket of money in it, right? And so these individuals are here for a reason, and they really want to serve these individuals. And so if I can hook into it, I think I can motivate them. I think the other part of it is focusing in on the symptoms and what we refer to as this in eliciting this patient mode as we talk about it. Anybody who's been at this rodeo for a long enough time and actually pays any attention they've had the experience. They've had the experience of walking in and asking about the meds and asking about the goals and asking about therapy and getting just a blank stare, one word answers. The person saying, can we be done with therapy? Like, so individuals, the providers understand that and they've had that experience. And so giving them this alternate way of thinking about it, it oftentimes mirrors those moments when they've had success. So it's really building on, this is when you've been successful and this is why it worked. So let's figure out how we do this all the time, right? That way, that thing that felt like a miracle, right? Miracles aren't, therapy shouldn't rely on being a miracle. Miracles happen once in a generation. It requires faith and we can't replicate it. But therapy can feel like magic, right? Magic, you just have to respond to your invitation and you can just do it time and time. You just learn how to do it over and over again. It's based off of really science, but it can feel, when I do CTR, when I do prolonged exposure, there's not a moment when I do this work that I don't feel like I'm doing magic. I can tell you all the science and I love talking about the science, but I feel like it's magic. So magic you can replicate over and over and over again. I think that's the difference. So helping clinicians hook into that. And then I think for some of the clinicians, also letting them know, that old phrase, anything that works isn't new. Anything that's new doesn't work. This isn't new. In 1976, Beck wrote in his book, Cognitive Therapy of the Emotional Disorders, page 9, second paragraph down, he talks about helping the patient draw on his own problem-solving apparatus. So Beck describes for us, if you read Cognitive Therapy of the Emotional Disorders, he's describing the recovery movement. Sure, it's laden in horrible 1970s, right? The writing's so beautiful because it's Tim, but it's horrible, language of gendered language and all that stuff that in 2025 we can't stand. Go back and read it. He's describing the recovery movement before it existed. And you go back to so many of these books, it's all in there about hooking into the individual's aspirations. But what happens is somebody gets their book of cognitive therapy for schizophrenia and they go, yeah, blah, 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 blah. Okay, delusions, right? So what happens is all of these books have them in there. I've read them all, but everybody just skips past the part about how to talk to somebody about their life. They're like, how do you get them to stop talking about their voices? And that's the problem. And I do in play and jest, over coffee breaks. I point that out to everybody. I said, the other books have it too. I just make you read it in order to find the parts about hallucinations. I
kind of read the book, I think one of the things that stood out to me is really, it is a change of mindset because it's so empowerment focused. And I think that's really, as I kind of read through it, it's like, it's getting away from stigmatizing language. I don't even think you refer to hallucinations. You use different language even in the book to, which I think sometimes... Yes, voice hearing, which is different. So I think that really is a change of mindset for the people that you work with. So the individuals maybe who do have schizophrenia or some type of psychosis. How hard is it for them to change that thinking? So they've been in a system. I'm guessing you're not the first treatment provider they see most of the time, and the system talks very differently to them. What was that process to help change their thinking in a different way?
I've had a lot of people say, because I always have the conversation that, I think if you're treating somebody with an anxiety disorder, as a good CBT therapist would go, this is, time limited and we're going to be efficient and we're going to get you back to your life. Everybody goes, of course, right? You charge a lot an hour. But I treat schizophrenia and I treat psychosis and people are like, well, oh no, I go to you forever because I'm broken. I've started using this phrase what will it look like when we break the gravitational pull of the mental health system? Let's start thinking about how do we do that? And I've had a couple of people in 1 week say the idea, because it was sort of once they got past the scared part of it, that's terrifying. They were like, I don't even know what that would look like. I've just been told that I'm broken for so long. That idea doesn't even make sense to me. And so I think there's many of them who find it relieving isn't the word, but they feel seen. They feel cared for. They feel respected, which isn't that what we all want as just a basic human thing? And they might recognize and maybe listen, I don't know that what I'm saying is right, but I just want to be respected. And they find it, they appreciate that piece of it. And then they recognize that that we might have to sort of look at these things in a different way at times. So I don't know if that answered your question.
Yeah, I think it does. And in the book, you kind of have this kind of metaphor of helping people be the captain of their ship. So this idea of really not being a passive recipient of treatment, but being kind of active in it. And, I think that's just a different mindset. And I don't work with psychosis. That's not kind of an area that I specialize in, but I feel like that's new for them.
Mm-hmm. Yeah. But so many of them talk about these stories of like earlier in their journey about, one of the most traumatizing pieces is the removal of autonomy, right? And if we just think about the experience, right? Let's take away the idea that this is an illness, right? Because I don't think there's any other mental disorder where we go, whether it's borderline personality disorder, whether it's depression, whether it's social anxiety disorder, where we just go, we're OCD, right? Where when somebody walks in the door, you go, and they're like really, really anxious or they're really, really upset. You start by going, that's your OCD. You start by validating, you go like, listen, I know that's scary, man. That doorknob was terrifying, right? And say, okay, let's sit down. I don't know that I'm going to tell you that the doorknob was okay because I don't know that's going to help you a whole lot. But I can see that you're really upset. Like there's a way that we talk to people in a humanizing way. And the minute we're talking about psychosis, we're like not everybody. Also, by the like, please, people who are listening, I'm not saying everybody out there. There are so many providers out there who are really caring and great about this. Sure. But so many people are ready to be like, that's not real. It's not the FBI. But think about it. Think about the experience of whatever's going on in your life. All of a sudden, you've come to the conclusion that people are trying to kill you. And you have lots of signs that point to it, right? You might be hearing things letting you know that it's happening. You're constantly thinking about being killed, and it's really taking a toll on your self-confidence. So you feel more vulnerable. You're not sleeping really well. And you're just feeling really scared. And then the first thing people do is they say, you don't have any control anymore. We're taking control and you don't have any say of it. That feels really bad. And it feels really scary. And it feels really traumatic. Having somebody who says, let's talk together, right? And again, I don't know if you guys have worked with, people who are mandated to come for drug and alcohol treatment, mandated for stuff like that. A lot of that sort of like rolling with resistance, all that stuff I learned with Fred Rogers when I went, not the one from Pittsburgh, but the one from PCOM, right. And doing motivational interviewing stuff, right? That way of like not getting into power struggles, right? It's that way of sort of getting alongside somebody and going like, yeah, it sucks that we're here together and let's figure our way out together, right? It's a meeting of two. I always say to people, it's a meeting of two experts. This is to people I train and oftentimes to individuals I serve. This is a meeting of two experts. You're the expert in your own life, where you want to go, and nobody understands better why you're experiencing what you're experiencing than you. And the only thing I bring to the game is how many people have recovered. And so in that, we're actually a perfect meeting. I'm not going to do your job, but you're going to let me do my job. And that in that we could actually be a really great team. And that's actually where the captain metaphor comes from. Yeah. A funny story. One of I had to develop what's called developmental editor when I was writing the book, who was really I just have like a deep love for her. It was such an amazing experience writing this book. And she just made it so wonderful. And she's like really hardcore. Her name's Christine Benton. And so, but she was always sort of like learning as she was sort of doing this, and you're right. This is like a very different way. She's like, I would never have thought about psychosis like this way, and not in a bad way, but it got to the part where I go, hey, if you really like your therapist, and they don't know how to do one of these things, here's how you could sit your therapist down and encourage them to go get some more training. Chris was like, dude, do you think a therapist, are you worried that like the therapist would get like really like offended by that? And I went, well, I think that would be diagnostic, right? If a therapist, if somebody says, I really like working with you, I need you to go learn this thing. And then they get really worked up and yell at you. They're probably not the best therapist for you. If instead you go, I really like working with you, I'd like you to learn this thing. And then together you guys figure out how they could do it. I think that would be good. So and you know what? She goes, what's funny? As soon as I wrote that, I actually knew that was going to be your answer. she was sort of got into it, which is really cool.
And it's something I just really appreciate, like in the book, like how approachable you're making this topic. And so I didn't go through a doctoral program of any, so I have my master's degree. And so I don't know that I got a lot of exposure talking about psychosis, and my experience working with individuals with psychosis is very limited, but it makes it approachable. It takes the themes, the concepts, the ideas that have already been taught, that have already been established, and makes them really engaging. And, when you're talking about the captain element of that, relating it back to how I approach conversations with individuals who've recently been diagnosed, especially adult ADHD, even to this point of like, so there can be a reason I'm not broken. I'm not, it's not that there's this fundamental flaw within me, but here can be an understanding of it. And, even I love that, like, I'm an expert and you're an expert. We're two experts meeting and we're working to kind of share this information. How do we manage ADHD well? And I want you to manage it, and I want you to be the manager. And knowing about it isn't going to change it, but knowing about it lets you take actions and steps to be effective and efficient. And like hearing those same elements that are coming across in these conversations you're having, and certainly across in the book as well. And I think it makes the idea of treating psychosis far more approachable.
Well, thank you. Thank you very much. That was one of the, when we were describing who the book would be good for. Obviously, it was written for individuals. I actually had a moment where my mom was reading the book. That is my real mom's name. My mom got hard name dropped in the book. And so she was reading the book and she called me at this like very weird hour of the morning where it's like, you don't want your mom calling you at that hour in the morning, right? Like she knows when I drive to work. So she called me like not at that hour in the morning. And she's sort of woken up early in the morning. She'd been reading the book the whole morning long. And this was like well before the book came out. And she goes, I just had to call you. Like, this book isn't just for individuals with psychosis, which I thought was a big coup that she was calling them individuals with psychosis now, which made me really excited. She goes, Aaron, do you know you wrote a book that could help families? She goes, do you know that? And it was like, I'm sitting there as like, of course, part of me is like, back then I was like 48 years old. I'm like, I was a 48-year-old going like, my mommy likes my book. And then I'm like an author going like, oh my gosh, this woman who has never read anything about psychosis cannot put the book down. I was like, I have got a book here, right? Like, so it was a dialectic in my brain. But the third group that was really important was providers, right? There's a really brilliant researcher. He's the chair of the Department of Psychology at Oxford University, Daniel Freeman. And he wrote a book a long time ago called Overcoming Paranoid and Suspicious Thoughts. And it's a great book because it's written to individuals, but every one of us who does CBT for psychosis has that book, has read that book multiple times. And it just kind of opens it up and makes it like, it's like, okay, this is how Daniel would talk to somebody. And so what I appreciate in what you were saying is that you feel like it's more approachable. And at the same time, what I know is every chapter in the book is written on the best science. And we actually have really good science on it that we have. So this isn't just like a big fever dream that I had sitting in my backyard and that I just like wrote these like sort of outlandish chapters about, Taylor Swift and pooping or whatever. It really is based off of like the persecutory delusions chapter is based off of research that culminated in an intervention that had a 1.2 effect size on reduction of conviction of persecutory delusions, which is the same effect size reduction that we have for social anxiety disorder. I mean, so when we're talking about, we have good interventions. And so it's really exciting that people could go, oh, this is really helpful and engaging. And I feel like I'm sitting next to a friend talking to me, but the friend just happens to be telling you stuff that could actually help.
Yeah.
And so that's the part that gets me really excited.
Yeah. And I think, as somebody who has done CBT and, have gone through all the trainings, I thought that was really the value of the book as a clinician who doesn't, again, work with this population necessarily, but it was so user friendly. It was so like, it makes it even like just breaking down some of the myths and things like that, these little things throughout the book that I went like, wow, okay, it gave me a language that I'll use different when I'm in those settings, which I always appreciate books that give you different language. So that's great. So
thank you so much. Thanks so much.
So Aaron, I want to jump back for a second. So, you've mentioned Tim Beck's work and the kind of cognitive behavior therapy of psychosis. But when you're talking about recovery-oriented cognitive therapy, it's not necessarily exactly the same. How are they related, or can you explain that maybe a little bit?
Sure. Yeah, it's a great question. So when we're talking about it, it really is an extension of CBT for psychosis, right?
Okay.
And so, but what we're doing is we're privileging, meaning we're putting first we're focusing on the negative symptoms. And so there's a couple of reasons we want to focus on negative symptoms. Negative symptoms are most associated with poor functioning, poorer quality of life, and shorter tenure in the community, more than hallucinations and delusions and cognitive deficits. Right. So that means that if you're being discharged from a hospital, if you have higher negative symptoms, it's more predictive of going back to the hospital. It's more predictive than your hallucinations and delusions and your neurocognitive deficits, which sort of flies in the face of what we would imagine, right? We would imagine the hallucinations and delusions are going to get you back in. Probably the cognitive deficits would be sort of second. And then, we used to say in trainings all the time, nobody ever got hospitalized for negative symptoms. Then these studies came out and we went, well, that's on us. We were wrong. Right. And so the other reason we want to focus in on it is you don't typically look for something that's not there. We look for things that are there, right? And so because negative symptoms are an absence of something, I'm very likely to focus in on somebody who's hearing somebody yelling at them, or I'm very focused on somebody who believes that they are the CEO of a company or whatever it is, right? That stuff draws our attention. It's like a bright light that our eyes go to. But we're not likely to focus in on the guy who believes he's the CEO of a company, right? Or believes that he's a demigod. We're not going to focus in on the fact that they are sitting in the room and they're not doing anything and they don't have any social connections and that they're not exhibiting any affect and that they're not producing a lot of language. And so we want to sort of tackle those and focus on those pieces first. We're still going to do the nuts and bolts that we would do with typical CBT for psychosis. So those are typical CBT for psychosis. Those are things like looking at beliefs about voices, doing a chain analysis around a strongly held belief or what we might refer to as a delusion and target those. But we're also going to typically focus on those as they are obstacles to moving toward the things that you want to do in your life. And so it really is prioritizing the action forward. And then really as the hallucinations, delusions, communication disturbance, which is like formal thought disorder, aggression, self-injury, memories, as those get in the way, then we're going to lock them in. There's some people who we kind of get them moving back toward their life. And a lot of those other pieces become somewhat irrelevant. And I've supervised many, many cases where really the voices become irrelevant, the beliefs become irrelevant, and we might do some cognitive restructuring around the underlying beliefs. So they learn those lessons in the context of moving toward where they're going. Other people, those symptoms really do get in the way, right? If I want to go and take my son to Penn State to tour around and see if he wants to go to school there, and the voices say, you can't go there because we're going to kill you, we're probably going to have to do something around those voices, right? It's probably going to be pretty scary to go do that. Or if the voices are even saying like, you're so stupid, he doesn't want you there, he's so embarrassed about you, mover, shaker, designer, maker, you're so stupid, right? And then I'm too embarrassed to leave my room. Well, we're probably going to have to do some work around that too, right? And so ultimately, those obstacles will get in the way. Same thing for memories that intrude, whatever those things are. And so while we're still doing all of the CBT for psychosis work, we're doing it in the context of moving toward the things that we want in our life. Instead of saying, let's identify all of the problems that we've got, and then how do we get to where we want to go in our life? Does that make sense?
It makes sense.
Yeah.
And like certainly recognizing the sense of developing a sense of motivation, developing a sense of connection. And that is just such a key piece, in the conversations Ray and I've had many individuals on many different topics. That we had a conversation about selective mutism and the importance and significance of developing motivation behind why the individuals are going to engage and what the experience is. And when you're talking about the hallucinations or, potentially hearing those voices say, oh, your son doesn't want you to go off to Penn State, it's embarrassing. Those belief systems can really create a barrier to engaging, which then keeps these individuals stuck in a negative feedback loop. And really finding a sense of purpose and value behind why are they doing what they're doing? What's the meaning? How do you make it engaging? And again, this even comes back to your comment about the hospital. And it's like, okay, well, what's your goal? And are you taking your meds versus, hey, the goal of being able to walk with your son through Penn State and being able to get his experience and seeing, sharing your experience and almost kind of seeing his eyes light up as he's kind of imagining what his own experiences are in tandem with yours. Like that's going to be a very different experience there. And so the importance of connection and motivation in here. And again, I think that ties in with so many other treatment models, which makes it far more accessible. And there are elements that feel scary or overwhelming, but really, again, grounding it into some of these pieces. And it doesn't take care of everything for everyone, but it makes it far more approachable.
No. I was going to say, you really say it really well. And a lot of times when I'm doing workshops, people come up to me and go like, this feels a lot like ACT, or it feels a lot like DBT. And I'm like, yeah. I mean, like, I think you see this in sort of like Life Worth Living. I think you see committed action toward a thing. I'm like, yeah, man. I was like, listen, we all walk by the same, Guilford booth at ABCT. We all go to we all eat at the same, we all see each other. We all like everybody's good, everybody's good like that. One of the things that we do, one of the ways that we're able to do that is that initial way that we break through to individuals. And so what's typically people go, oh, that's just engagement, or, oh, that's just sort of rapport building. We're actually using it very strategically, almost like a behavioral experiment. And so, because you just really drew it out nicely, that idea of these beliefs are so activated. I've really been thinking of how beliefs come almost like in opposing muscles. How like when you flex your bicep, your tricep releases. And so when you flex the adaptive mode, the patient mode is released, right? And yet when you flex the patient mode, the adaptive mode, you release that and you don't have that. And that's when you see these different sides of the individual really activated. And so, I mean, anybody who's ever done this work, even if you did it all the way back when you were like an intern or on a practicum, almost anybody I ever ask always has this experience. Have you ever gone in and asked all the questions you had to ask about medicine, groups, all that stuff? Where you go, yeah. And you got one word answers. Yeah. And then I go, listen, we're all friends now, right? We've been doing this podcast now for, however many minutes, right? Let's be honest. You ever go, oh, heck, did you see the Eagles play? And then all of a sudden this dude who wouldn't talk two words to you just explodes tells you a whole dissertation about what the Eagles need to do and if they're going to make it to the Super Bowl this year. And you're like, whoa, where did this dude come from? Right. But it's this. We're sort of like flexing this muscle about connection and knowledge and capability, right? Those are core beliefs, right? I like to talk about beliefs as lessons because it gets people out of this very like bookish way of seeing it. And if you have one lesson, you can learn a different lesson. It feels a little bit more flexible in the way we approach them. And so in that moment, we're sort of flexing it and it gives an initial behavioral experiment to test out. Connecting with other people isn't worth the effort, which is associated with asociality, right? Or if I say, listen, my legs are killing me, let's go for a walk, and we go for a walk, and somebody has this belief of, I can't do it until I get the energy, but they find that they have more energy. So we use those pieces as an initial behavioral experiment when we activate this adaptive mode. But that's sort of like when you go to Costco and you like taste something and then you put it, but you're like, oh, this is great. So you put it in your basket. It's sort of the same thing here. You had that, like you go for that walk. Well, you could put that on your activity for the week. And that starts to construct an activity schedule kind of slowly but surely. And so that activation sort of builds that person's energy up. It ultimately leads us to the point that we can sort of elicit those aspirations, right? And those aspirations, we go back. Actually, Paul, the way you described walking around Penn State is so vivid, right? Tim used to say to us all the time, you should know the breed of the dog that the individual is going to have in the apartment that they get when they get out of the hospital. That's the way how vivid of an aspiration you should have, right? And so once you make it really vivid, which is again, activating the individual around, I can connect to other people, I matter, I have a future, right? Then that's when we start planning action toward it. And those are sort of the steps of,
well, it does, fellow Penn State alum. So, we are. So we are. When you're describing that, like, I can just even imagine that even so, but like the way you were describing, like, so the importance of also willingness to connect. And I certainly had that. Yeah, I don't know that I was asking about the Eagles, but, whether it's asking about Lions or whatever that may be, but being able to really have those moments that just elicit that response. And even if I think the importance of exploration of interest, and I think we've talked previously about case conceptualization, and instead of there being this diagnostic, I think Ray, you had mentioned like they're a kiddo who likes Star Wars, like really bringing in like those elements of them before we're ever talking about what's the symptom presentation. And so getting to really understand the person well first. And I hear, again, this model really just exemplifies the importance of, yes, we need to have a strong understanding of the symptom presentation, but we also need to know the person that we're sitting across from as well.
Yeah. And I think, and I think you're making such a great point in that. And I think one of the things that the individuals sort of show us, I would say the individuals you serve are the best trainers ever, because if you don't get it right, really do. It's like there's one theorist who talks about that, like negative symptoms act like a circuit breaker. There's no like, like you have a session with somebody and you're like, there's like an ambiguity. You're like, I don't know if I hit there. Good news. The individuals we serve, it's like a circuit breaker. You kind of like hit it wrong. It's like, and they really kind of like, it's sort of, they've shut that. It's over. I mean, not everybody, but some of them, it'll go that much. And so it is knowing the person. It is having that ability to connect or having that desire to connect with the person. Right. So I've had examples of, when I was at Penn, I was at Penn for about 10 years and we did work all around Georgia. So I would go into the field and I would demonstrate for people I was training. And so I was going in blind, never having met some of these people before. I grew up in New Jersey, living in Pennsylvania, going into all parts of like rural Georgia, whatever. And so, I would go in and I would like, somebody would like walk in and they had like Mets pants on. I'd be like, oh, you're a Mets fan. And they're like, no, I got this at the Goodwill. And that was it. And they were just like super flat. And I'm like, oh, okay, cool. What was for dinner? And then just persistently went on there. But they were like, why? Wow, this guy really like kind of wants to get it. They were like, okay. But like the interest, the desire to connect, it kind of were like, actually sort of like what Ray was saying before. Like they're kind of like, this dude's weird and kind of different. And then they're kind of like start leaning in a little bit more. And then if you schmooze in, if you find enough, if you poke enough, eventually one of them will open the door, And
the importance of vulnerability as a clinician to do that.
Yeah.
And the vulnerability and humility of we are going to swing and miss far more than we're going to connect. But once we connect, we can strike that nerve. We can really follow it back. And sometimes it leads to a dead end, but we can also, usually there's something then connective or nearby that we can grasp onto and then continue on that pathway. And so the vulnerability to really, again, mirroring that and really kind of modeling that for the individuals of it doesn't have to be flat. It doesn't have to be disconnecting. You don't have to feel isolated and alone. And it's inviting them to join you in that sense of connection there. And even if they're only a Mets pants from the Goodwill, it's, so we're not good. Equally good information. Now I don't need to bring up the Mets anymore because that's not going to be a direction that we're needed to go.
And even when I'm training people, oftentimes try to select not video of me being like amazingly brilliant. I mean, like I obviously I choose like good examples, but oftentimes I have this one. It's like I don't ever do it when I do virtual trainings, but when they're live. So I haven't really used the live videos in a very long time. But I love when I get to do live trainings because I've got one video where it's a person and like I keep going, and it's called Activation, the Importance of Persistence. And it's literally me like trying to activate this guy like 5 times. And it's like on this thing and it's just like strike 1, strike 2, strike 3, strike 4, strike 5. And then finally I'm like, I'd say something about like I have a truck and I had like rented a car and it was like in Georgia and I rented a car and they only had like F-150s or F-250s. And you don't know me, but like I definitely don't like come across as like the guy who's going to be driving around in an F-250. And he's like, and then that got his attention. And then we started talking about coffee and he likes coffee and I like coffee. We both drink it black. And it was like, and that was and that's how we did it. I mean, I share the video and people are like, wow. Oh man, that's great. I'm like, yeah. I said, and now I'm going to tell you something that's really going to shock you. And they go, what? I said, the real clip is 2 times as long. What do you mean? I said, I can't show you the whole clip because like it's just too long. So I actually struck out twice as long as what I showed you, but I only showed you that. And they're like, that's sick. I was like, so it's, but just having that vulnerability with trainees too, to let them know, yeah, man, some of like my favorite videos are the ones where I start at the end of the video, I go, okay, so how did I mess that one up? Like, and this is like a room of 100 people. So what did I do wrong in there? And then it's exciting because people are like, oh, I saw, oh, right. And they can see the thing I trained them to not do. They go, oh, that is what happens when you do the thing that you tell everybody not to do. I was like, yeah.
I mean, I think that the vulnerability is good. But I think the other, key that is, and we've heard this with other kind of guests who have talked about treatment, just the curiosity. I mean, I think that this idea of being curious about people, and I think I always say when I do trainings, the biggest mistake we do is people sit down and we start asking them what's wrong, and we start trying to dig for symptoms or, and instead of just kind of sitting down and being curious about them. And it's hard. I mean, part of it, is hard because many are not used to that in treatment. They're used to somebody saying, so tell me why you're here today. But when you kind of, try to go like, tell me a little bit about what makes you tick, like, whether it's the Mets or whatever. I mean, and I find that it's like, I don't know that I've ever had one that I haven't found that nugget to connect. But there's been some long ones. I think my longest was 3 sessions, like three sessions where it was like just dropping duds. But then when it does, it's different. And I'm going to kind of bring it back to, kind of as we're running out of time, bring it back to the book for a second. I think one of the big things for me at the end of the book was I think you used the term feasting on great parts of life, some terminology like that. So I told you I'm going to make you recall your quotes in the book. But this living your best life. I think we can't get to that with people if we don't get to know them first. Like, I think this curiosity and this connection, then they can be vulnerable back to say, hey, yeah, this is what I want to do to live this fulfilling life. And it breaks it away from, did you take your meds? Have you been hallucinating? Whatever terms we kind of use or questions. I think just such a different mindset. And, I know this book is kind of for people to read and do some work on their own and maybe use in therapy. But again, as a therapist, when I read it, I kind of went, yeah, gosh, if we really are curious and we really try to get to understand people, we can really get to these key points for them.
Thank you. Yeah, I agree with you about the curiosity piece of it. I think that's something I try to infuse in my own work, is to always remain curious for people. And I also think it's important to recognize that being curious doesn't mean that we have to, I think there's this idea that curiosity and we need 100 sessions to be curious are synonymous. I think we can be curious and, Columbo was actually really curious, but really efficient, right?
Right.
Because I think these things hurt people. I mean, I think people are hurting, and we do have ideas. I mean, I think that's the meeting of two experts, right?
Yeah.
But I agree with you. I think it's really about getting people back to living their life and really feasting on recognizing that. I've done some trainings in like really religious communities, right? So I did a training once, or I've did a couple trainings with the ultra Orthodox Jewish community, and I did it with the Mormon community in Salt Lake City. And obviously I did all Georgia, but it was really interesting because in the Orthodox community, there's this idea of the path, right? They call it the derech, right? And they describe how people leave the derech. They go off the derech, which is the path of sort of light, right? And I thought it was such an interesting image. It's an interesting metaphor, right? And and I started using it. I started talking about it. And when I was in Salt Lake City, I sort of talked about this idea because I knew they were a very religious community. Most of the people there were really religious. And my host said, it's so interesting that you talked about that. Because do you know that the Mormons have this idea of this called the path of it's like the path of light in the iron rod. And there's sort of these pieces. And so for both of them, I always have this image of our work, what we are allowed to do is we're asked to purposefully leave this path and to search people out who were dragged from the path, not of their own choosing. And I'm also, before somebody starts sending nasty emails to, Paul and Ray, I'm not proselytizing here at all, right? I just think it's an image because I think everybody in life has a path that they're on.
Yeah.
And I know that mental illness drags people from that path and steals people from that path. And what we have the good fortune to do is to go and help find those people and help them find their way back to the path and learn how to stay on that path. And I don't know that it's always the easiest of jobs, but seeing them do it is just the greatest gift. And I think both of your points are so important of that curiosity and that care and that seeing people as people. Every individual I serve, I recognize that there's somebody's daughter and somebody's son, that they might be somebody's brother or sister or father or mother. And they're people who matter. And it's at a time right now where they are under assault, and the assault is to push them back into institutions and hide them away and blame them for the ills of our society right now. And it's just at a time when we have such good science to help them get better. And so I just think that we have such a gift for us to be able to serve these individuals.
Well, I really appreciate kind of everything you shared today. And, I really enjoyed reading the book, and hopefully everyone will check it out. As we kind of wrap up, we always like to kind of end with a kind of two questions that we ask all of our guests. One, not a hard question, but we'll put you on the spot. Other than your own books, what's maybe one book or some content that you would recommend people check out, whether it be another book, another podcast, movie, whatever you're comfortable sharing? What's one thing?
Sure. One thing.
Yeah.
There is a team called Skits and Giggles, and it's two influencers. One of them is, her name's Kit Wallace. She goes by Schizo, and she has schizoaffective disorder. And then Cody Green, who he goes by Schizophrenic Hippie. And they do a podcast together. It's every Friday. And they're just this great team. I listen to them every Friday, and I comment on every one of theirs. And it's great. You can see them on YouTube and on Spotify and on Apple and everywhere you can find those things. They're really good. And if you wanted a really great book to really kind of dive into this idea of like breaking the idea of it, Paranoia by Daniel Freeman. And it's a great book because it's a beautiful mixture of, it's almost like a memoir of Daniel's journey through his research. But it's also like a review of his research through mistrust. And it's just brilliant. And it has a historical bend. It has a story about Tim, and he's just the greatest writer. And he's just a really great guy. But it really, if any of the stuff in Living Well sort of piqued your interest and you really want to kind of crack your brain open a little bit, it's just a great one. Yeah,
and I have to say, Skits and Giggles might now be my new favorite name of a podcast. Like what a clever, like that's brilliant, it's so right?
Interesting.
I can't to check it out.
Yeah, Schizo. Kit Wallace, her dad, I think, came up with the idea of Skits and Giggles because I think her dad came up with the idea. She said somehow her dad was involved in sort of either vetting or coming up with the idea of skits, and so she is a very powerful upcoming advocate, and you've got to see like her YouTube stuff, like, and each of them have their own content on their own, and their content is amazing. Like she does these amazing like DBT deep dives, and they talk about their life experience, and they're the two of them. I mean, all the people in that space are really great, but their podcast is pretty wicked.
Well, we'll have to check it out. We'll share it in the show notes as well to make sure others do as well. Last question before we wrap up. If you could give us, what are your 3 takeaways for our audience from doing the work that you do?
Sure. So the first takeaway is that this work is extremely rewarding and exciting and creative and wonderful. And also it allows you to actually draw in a whole bunch of skills. So I think a lot of times people go, I could never start doing that work. And I'm sort of proof positive that like I wrote every paper, even when I was in internship, like I didn't even do the rotation for the schizophrenia rotation when I was there because there was like some problem. They didn't let us do it. So if this made you sort of psychosis curious, there's a great need out there. 2, we need voices, and we need voices out there speaking up and speaking out. If you see something, say something. Anybody listening to this podcast is somebody who is smart and powerful and clearly kind of keys in to gather knowledge. And, as Ben Parker once said, with great power comes great responsibility. And we are at a time where we need to stand up and speak out and protect those who don't have the ability to protect themselves because they are scared. And I can speak for the individuals I serve. They are scared because they're under assault. And the last takeaway is always keep growing. Right. One of the things that I just love is I think a lot of my trainees, when I get to work with them, and I just love that opportunity, is they go, my gosh, where did you get all they have this person and I have like an imagery exercise, or I have a progressive muscle relaxation, or I have deep breathing, or I have, I know about the spectator thing. And it's definitely not because I'm like this super smart guy, right? It's because every chance I get, I kind of sit down and I kind of like just take a moment and I read it and I practice it and I try it, right? And I've been on a lot of clinical trials, so I've you have to kind of do it at a certain level when you've done that. But you deserve that growth, and to keep doing this work in the long run, that excitement of always learning something new, it will make it's what makes it so exciting. I mean, talking to two of you guys today, I can see this is why you're excited about it. It's so just like give yourself a period of time, like whether it's an hour a week or whatever, but just to learn something new. It doesn't have to be a whole book. It might be a podcast. It might be a YouTube channel that has and you just practice something, but like just choose something new and do something to challenge yourself to learn something new every week. Maybe it's a full course and you learn like DBT. Maybe it's you learn 5 senses and you crush it, but just always be learning, because it's just, and not in that like cheesy way we were all taught about in class, and but like in that like really like it's really fun to have like these, to just feel you just feel so empowered to serve these individuals. So, and have fun. That's
right. 5. Awesome. So glad you got to join us today. We're excited about your book and excited to have you here. So thank you. And we're really going to get people, we'll have a link for your book on the website. So, or on our show notes to make sure that they can check it out.
Truly, Aaron, thank you so much. And if our listeners are interested in hearing more, staying up to date, where can they go to follow you at?
So I'm on YouTube at Recover with CBT. I'm also on Facebook under Aaron P. Brinen. And I think it also comes up as Recover with CBT. And I'm on Instagram at Recover with CBT. Keep it nice and easy for everybody. And so, I'm on other platforms too, but those are sort of the big ones. And I've got a website. I don't want to shock everybody. It's recoverwithcbt.com. So thanks for everybody. And if this is helpful, please sort of pass it along and let me know, because this has been just a really great day, and it's been a really cool experience getting this stuff out there for people.
Well, consistency is key. So certainly having that down, and hoping our audience takes the time to go and check that out. Also checking out the book. It's a great resource. And again, as Ray said, check out the link in our show notes. And if you're a licensed clinician who would like to use this information, please head over to www.psychtopractice.com or check out our show notes for a link to purchase the accompanying exam for continuing education units for this episode. If you're interested in hearing more or staying up to date with what's going on for Psych to Practice, you can visit our website, or you can follow us on all major social media by searching Psych to Practice. We'll be back in 2 weeks, but until then, be well, stay psyched.